We love y'all.
Little victories.
Literally. You have no idea. Does anybody by chance have any ibuprofen?
Luckily I do.
You do? Oh my gosh, can I have some? Thank you.
Morning, guys.
Good morning.
Just waiting on Kristen. Today we're just gonna finish up our liver vasculature, like portal vein thrombosis. And then we're gonna kind of shift gears a little bit and go back to that statistic portion that we skipped early on with like.
I was looking at it and I was like, what?
Yeah. I don't know why they decided to throw that on the vascular registry as opposed to any of the other ones, but it's on your vascular registry. But once you figure out how to set up your Punnett square, your little chi-square, you know, you can answer any of these questions.
Okay.
So when you sit for your vascular boards, first thing you do is just write out your square and you can answer all these statistic questions. Okay. It's really not that bad. So we're gonna pick up with portal vein thrombosis or occlusion. So this is frequently a consequence of cirrhosis and portal hypertension. So 20% of all cases of portal vein thrombosis are due to cirrhosis. Another 20% are due to malignancies like hepatocellular carcinoma or pancreatic cancer. And this is due to direct invasion or extrinsic compression on the portal vein itself. So you could have a large mass on the head of the pancreas that's actually compressing the portal vein. So again, that goes back to our virtuous triad where you're compressing a vessel, so extrinsic compression that can cause stasis of blood, as well as these cancers causing a hypercoagulable state as well. So, you know, particularly pancreatic cancer, you know, causes the patients to develop clots more readily. So the causes, again, of portal vein thrombosis are stagnant flow in the portal vein as a result of cirrhosis. So the cirrhosis itself causes elevated pressures within that portal vein. So those elevated pressures in the portal vein then cause the blood flow to become more stagnant, start slowing down, and as it slows down, it gets a chance to congeal, form into those clots. Other conditions that can lead to portal vein thrombosis, again, are things that put you in a hypercoagulable state, like pregnancy, oral contraceptives, again, different malignancies, surgery, post-surgical complications from like biliary surgery could potentially lead to portal vein thrombosis, as well as trauma. And there are some idiopathic conditions as well, so could potentially be from unknown causes. So some signs and symptoms for portal vein thrombosis. Patients will have abdominal pain. They can potentially have a low-grade fever. So anytime you have thrombosis within those vessels, You can even have DVT in the legs. Sometimes the patients will develop a low-grade fever. So I've had orders come in, fever of unknown origin, rule out, portal vein thrombosis, or even I've had fever of unknown origin assessed for DVT in the legs. So they'll also have leukocytosis elevated, which is an elevated white count, hypovolemia. They could develop shock. And there's also hemodynamic consequences from portal vein thrombosis. There's the portal hypertension and also the development of portosplenic collaterals. So this, remember, the portal vein is that main source of blood flow for the liver. So 80% of the blood flow 80% of the liver's blood supply comes from the portal vein. So when it's occluded or thrombosed, that liver is starving for blood. So you're going to develop collaterals to try and get around that clot to bring blood flow into the liver. We're going to see in a moment, that process is known as cavernous transformation. So we're going to see it as pretty unique on ultrasound. I remember the first time I saw cavernous transformation, I'm like, what is going on here? It just looks like a jumbled mess of vessels going into the liver. Again, leukocytosis is an abnormally large number of leukocytes, so an elevated white count, which is observed in acute infection. Hypovolemia is a deficiency in the amount of blood in the body. And let's see. Okay, so again, so these patients can enter into shock. So unlikely unless the bowel becomes infarcted. And there's a sudden insufficiency of blood supply. May also be present with abdominal rigidity, elevated LFTs, nausea, vomiting, vomiting of blood, hematemesis, Melania, which is the passage of dark colored stools, and also the presence of altered interstitial intestinal juices. So when we're doing our ultrasound evaluation, so we perform in a postprandial state. So after the patients have eaten, we give patients a high caloric drink and wait 30 minutes. We use color and Doppler to distinguish intramural echogenic material, such as a tumor versus thrombus. So again, if it's actually tumor that's innervated, the portal vein, that tumor will have vascular flow to it, whereas thrombus itself will not have internal vascularity. So we can differentiate between mass versus thrombus. So it's an acute finding. Yeah, bless you. So we have to realize that failure to visualize the main portal vein is an acute finding. So say it's thrombosed and we can't detect it or we can't see it. We have to that has to raise red flags in your mind, like what's going on? You're like, why don't I see this patient's portal vein? Potentially it could be thrombosed and maybe contracted, and it could potentially look like, the bile duct. So I actually had one patient, this elderly gentleman who came in, he had a scan at the outpatient office, and he thought he was there because he was having like a gallbladder issue and it's just gonna be a quick thing. So they thought his CBD was dilated. But when I put the probe down, I was able to see CBD, and then I see like the portal vein and actually thrombus within. I was like, oh my gosh, they were measuring this guy's portal vein as the common bile duct, thinking he had a dilated CBD and it was like a gallbladder issue or something. But his portal vein was all thrombosed, and I could see it like thrombosed and then branch and thrombosed into the liver. It was like, so he's like, so this is just gonna be a quick surgery, right? I'll be in and out, right? They told me just remove my gallbladder and I'll be good. I'm like, oh yeah. Your doctor will speak to you. So we're going to detect intraluminal echogenic material. We're going to document absence of flow on color Doppler. And we're also going to look for dilatation of the vein. So the main portal vein. We'll look for diameters over that 13 millimeters. So remember that also coincides with our portal hypertension. So when we're measuring the portal vein, when we get measurements over 1.3 centimeters or 13 millimeters, could also indicate the presence of portal hypertension as well. So tumors will demonstrate pulsatile flow. It's typically going to be low resistance flow. Thrombosis, there'll be no flow or occasional continuous flow. If it's partially blocked. So we also have to assess for, the extent of thrombosis. So this thrombosis could extend back in towards the splenic vein and the superior mesenteric veins. So it's important to check your confluences and track back towards the splenic vein as well as the superior mesenteric veins. And we are also going to document the presence of any intrahepatic or extrahepatic collateral vessels that may be developing. So if the patient's had long-standing portal vein thrombosis or occlusion, we may encounter chronic findings. So the portal vein undergoes fibrosis. So with this fibrosis, it becomes more epigenic. It starts becoming narrower. It's almost like starts collapsing in on itself. You're not going to visualize any flow within it. And this leads into that cavernous transformation of the portal vein. So this is the development of paraportal collaterals, and it's the principal manifestation of chronic portal vein thrombosis. So this is the development of portosplenic collaterals. You'll also see lobar atrophy, so the lobes will begin to shrink and atrophy. So portal vein caliber may indeed be less than 13 millimeters at this point. You'll see thickening and irregularity of the vessel walls in the area and areas of calcification. So it becomes very echogenic, becomes very tortuous and irregular. Like instead of a nice smooth portal vein coming into the liver, they'll start kinking, get tortuous, the walls become thickened and very bright. Resolution by recanalization or development of there's resolution by recanalization or by development of periportal collaterals. So ultrasound diagnosis is highly accurate. False positive results and pitfalls for this test could be potentially undetected slow flow. So if you're ever suspicious of portal vein thrombosis, throw your power Doppler on. So even though you may not be detecting flow with your regular color flow, the flow just might be very stagnant, very slow, and your power Doppler would be enough, to detect the flow. So if you don't see any intraluminal echoes, but you're not detecting flow, always throw your power Doppler on. Some other pitfalls could potentially be inadequate Doppler angle. So maybe you're at 90 degrees, you got to change your angles, change your window. And then also recently formed thrombus may remain undetected. So remember, with portal hypertension, there may be low velocity or to and fro flow that is difficult to detect, causing a false positive. Again, make sure your angles are correct. The stages of ultrasound findings. So in the early stages, we'll see the echogenic thrombus and the vessel lumen. As it progresses, thrombus and small collaterals are visible in the immediate area. And then at end stage, with chronic portal vein thrombosis, we develop those large collaterals, which is termed cavernous transformation of the portal vein. Again, cavernous transformation is the result of long-standing thrombus and subsequent collateral vessel formation. Multiple worm-like vessels can be seen in the portal vein. Predominantly in patients with normal liver. This is rare in the cirrhotic patient. Development of paracoledocal veins and recanalized areas of thrombus may extend into intrahepatic branches. Portal vein occlusion is usually permanent, though recanalization occurs in some. Recanalization is the restoration of lumen in the blood vessel following a thrombotic occlusion, or by organization of thrombus through the formation of a new channel. So here we go. This is a picture showing TMS. Should I turn that light off or is it okay? We have our gallbladder pointing to a dilated common hepatic duct. So this is actually the main portal vein coming in. You can see the heterogeneous epigenic thrombus within the actual vessel itself. This is the main portal vein in a patient with pancreatic sarcoma. So this is actually, echogenic tumor. So tumor thrombus. Let's see if they have a picture with color on. There we go. So these are some more pictures showing you have a dilated main portal vein coming in. You can see focal areas of tumor or thrombus. Important that to note that the thrombus, can be partially occlusive. So in some cases, we can actually have some thrombus within the vessel and clot and flow, going around that thrombus. So the left image shows thrombus partially occluding the main portal vein, the patient with pancreatitis. The right image is a dilated acute partial thrombosis of the portal vein. Some more pictures demonstrating that main portal vein. So it's also important to, assess your branches, your right and left branches of the main portal vein, because thrombus can be visualized intrahepatic as well. So this was a transverse view showing the left lobe of the liver and the left portal vein containing echogenic thrombus. And then the follow-up contrast CT demonstrating the thrombus in the same segment of the left portal vein. Top thrombus, similar echogenicity to the liver. Which is including the portal vein. So when you put your color flow on, again, no detectable flow. You can see in this picture, it's branching out into your right and left portal veins. And this is now pictures for some non-obstructive portal vein thrombosis. This is why it's important to get a good 2D image as well as a good color. So if you had your color gain too high, you could potentially be covering that entire thrombus and have it bleed over. So this has blooming artifact, obscures the majority of the portal vein thrombus, making detection difficult. There is very unusual. It is very unusual for a portal thrombosis to be present when Doppler examination is normal. One situation of this can happen is when colored blooming artifact obscures focal non-obstructive thrombus. So some false positives for portal vein thrombosis. So in A, an initial color image reveals no flow in the main portal vein, suggestive of portal vein thrombosis. So in this case, the technologists had their scale set too high. So we weren't detecting any flow within that portal vein. So they lowered their scale, they lowered their PRF, and it fills beautifully with color now. So again, slow portal venous flow simulating thrombosis. So this is an oblique view of the porta hepatis showing no detectable flow. Similar view obtained during compression of the lower abdomen. So this augments the mesenteric venous flow and increases flow volume and velocity in the main portal vein so that it becomes detectable. So those, and also mentioning that those low level echoes in the portal vein may be due to artifact as well. So you also don't want your gains set too high where you're creating those intraluminal echoes as well. So this is now hepatocellular carcinoma, which has invaded the main portal vein. So a macroscopic portal vein invasion is present in about 16% of patients undergoing hepatic resection for hepatocellular carcinoma. So portal vein tumor thrombus, a patient with hepatocellular carcinoma. So with tumor thrombus, it often expands the lumen and it may contain small cystic spaces. So invasion starts in the peripheral veins and grows into the more central portal veins. Detection of hepatofugal arterial flow and portal thrombus is diagnostic of tumor. So if we're detecting an arterial signal or hepatofugal arterial flow in the portal thrombus, this can be a diagnostic characteristic of tumor. Visualization of internal vascularity is sometimes present, or avascular arterial flow is usually hepatofugal in the opposite direction of the portal vein. So sometimes we'll see small tumor vessels within the thrombus. That's how we can differentiate between tumor versus straight thrombus. Again, with portal vein tumor thrombus, typically begins in the smaller branches and works its way into the larger. So we'll check the smaller branches for presence of tumor thrombus as well. Again, this is a patient with hepatocellular carcinoma with some oblique views. So you can see thrombosis of the branch vessels. So your left branches. So in this case, they did a fine needle aspiration and were able to take samples for biopsy. Okay. This patient had no detectable flow in the periportal arteries. MR shows thrombus in the portal vein. They did a portal fine needle aspiration to sample the tumor within the vessel. So here you can see actually the echogenic line, that's the needle tip entering in. So they did a fine needle aspiration to take a sample. So here we have a picture for portal vein occlusion. So again, no color flow demonstrated. Distension of the main portal vein. So in this case, it measured 4 centimeters or 4 millimeters. And no flow in the splenic vein as well. So we have a good image with our pancreas. Splenic vein underneath the tail of the pancreas. It's also demonstrated no flow. Now we're getting into our cavernous transformation. So this is what we see when we have long-standing portal vein thrombosis that's now become a chronic condition for this patient. So we have the development of periportal venous collaterals in the hepatoduodenal ligament. This is a patient with long-standing portal vein thrombosis. So we have a transverse view of the porta hepatis and shows multiple tortuous vascular channels and no defined portal vein seen. So with this cavernous transformation, trying to find that actual main portal vein becomes almost impossible because at this point it's become fibrotic, it's collapsed in on itself, and what's really taken over now are these collateral channels. So these collateral channels form relatively rapidly and have been documented to form as soon as 6 to 20 days prior portal vein thrombosis, after portal vein thrombosis. Even though it's thought unusual, however, cavernous transformation may also develop when portal vein is compromised but not completely thrombosed. So a single periportal collateral may be mistaken for a patient's main portal vein. So be careful that you're not just Dopplering or imaging collateral thinking that that's the main portal vein. The normal portal vein travels deep into the right of the hepatic artery, and the periportal collaterals travel anterior to the right hepatic artery. So again, in our normal picture, when we're imaging, we typically have, our main portal vein and then the hepatic artery line anterior to that. So it's usually above. These periportal collaterals are typically above the hepatic artery. So if you're able to find your hepatic artery, you can kind of tell the relation where these collaterals are in relation to the hepatic artery to differentiate between your main portal versus just the collateral. So arterial enlargement usually occurs in cirrhosis and portal hypertension and can be distinguished from venous collaterals by Doppler analysis. Again, so this is now a tangle of vessels seen at the porta hepatis. And now we're in a sagittal view coming in. So you can see just a whole kind of tangled mess of vessels. So if I was to put color on that, these are probably all light up with color. And again, it's very hard to distinguish now what your main portal vein is. So this is now a longitudinal image for the porta hepatis showing blood flow through tortuous cystic structures. And no normal portal vein is seen. So extrahepatic portal vein is not visualized. There's echogenic areas present in the porta hepatis, and periportal collaterals are present. Some more pictures just showing that cavernous transformation. So when you see this once in ultrasound, you'll never forget it. In this case, they put powered Doppler on, so it looked like some of these areas weren't filling with color, just slow flow. And when they put powered Doppler on, those anechoic areas were able to fill with color. So again, so portal cavernous transformation is a result of long-standing chronic portal vein thrombosis. We don't have a discernible main portal vein at this point because it's become fibrotic and replaced by these collateral channels. And then one of the last things we're going to discuss is portal vein aneurysm. This is showing a focal dilatation of the main portal vein. This is actually a congenital aneurysm. You can also have portal vein gas. So etiologies could be bowel ischemia, things like diverticulitis, appendicitis, bowel distension, bowel obstruction, inflammatory bowel disease, interstitial pneumomatosis, abdominal abscess, sepsis, hypertrophic pyloric stenosis, gastrointestinal cancers. Could result with patients following endoscopy or variant enemas. So this can accumulate in the peripheral intrahepatic branches of the liver or liver parenchyma. Should be followed carefully with sonographic inspection of the rest of the abdomen for possible bowel ischemia. So in this picture, we're showing our oblique view of our main portal vein at the hilum. So these little bubbles within the vessel demonstrate little gas bubbles within the portal vein. Doppler waveform shows multiple bright signals embedded within the main portal vein. So these represent strong reflections from the gas bubbles. So when we do our spectral Doppler, we get these artifacts, these almost like a twinkle artifact, if you want to think of it that way. When we Doppler, and that's indicative of the gas bubbles within the main portal vein. So these artificial signal spikes are associated with these bubbles. So another important condition that we need to discuss, particularly with the liver, the two main things we look for are portal hypertension, portal vein thrombosis, and then Budd-Chiari syndrome. Again, all right, so Budd-Chiari syndrome. So Budd-Chiari syndrome is going to be when we have occlusion or thrombosis of all the hepatic veins and or occlusion of the IVC at the microscopic level. So this occlusion is due to thrombosis, could also potentially be due to compression, tumor infiltration or stenosis. So it's occlusion of our hepatic veins. So this is blood flow draining out of the liver. So Budd-Chiari is a drainage issue. Portal hypertension is a blood flow entrance issue. So primary causes could be caused by congenital obstruction of the hepatic veins or by IVC or the IVC by membranous webs. Secondary causes could be due to obstruction by tumor or thrombus formation within the hepatic veins. So primary, something you're born with, a congenital issue. Secondary, due to either obstruction by tumor or thrombus formation. The Budd-Chiari syndrome causes, so causes of thrombosis. So this would be causes of secondary Budd-Chiari syndrome. It could be oral contraceptives, myeloproliferative processes are more common, like polycythemia. Could also be a result of coagulation abnormalities like chronic leukemia, a paroxysmal nocturnal hemoglobinuria. Additional causes of thrombus could also potentially be trauma. Could be compression of the IVC, due to pregnancy or from tumor. Other causes could be tumor infiltration. So from hepatocellular carcinoma, renal cell carcinoma, adrenal cortical carcinoma, leiomyosarcoma of the RBC. Or we could have our primary causes, which we can do include congenital abnormalities or an obstructing membrane, potentially also infection as well. So primary sites of obstruction for Budd-Chiari syndrome, we have sinusoidal occlusion at the level of the sinusoids, primary hepatic vein occlusion, also IVC occlusion or stenosis. It can also potentially be caused by congestive heart failure or pericardial tamponade. So with pericardial tamponade, that's the development of fluid around the heart, the pericardial space around the heart, and that causes changes in pressures in the heart and blood flow in the heart to become stagnant. So the blood flow moving through the heart actually starts to slow down. So when it starts to slow down, it will start backing up into that IVC. So we know when we're doing our imaging, we're able to visualize, the hepatic veins draining into the IVC, and the heart's right there. So it's in close proximity to that right atria. So when things start slowing down in the heart with congestive heart failure or pericardial tamponade, that can lead to stenosis or not stenosis, lead to thrombus formation within the IVC and back up into the hepatic veins. So signs and symptoms for Budd-Chiari syndrome. We think of young females potentially taking oral contraceptives. These patients will also have abdominal pain. There'll be development of ascites. They'll have hepatomegaly and splenomegaly. So think about it. So blood flow now is going into the liver, but it's not draining out. So that liver is going to become engorged. Things are going to start backing up. So we'll get the hepatomegaly. If it backs up continuously into, through that main portal vein into the spleen vein, they'll have splenomegaly. These patients will also develop lower extremity edema as well. Therapy includes anticoagulation, surgical shunting. So this could be potentially a tip shunt or even liver transplantation. So ultrasound evaluation for Budd-Chiari syndrome. So we're going to document the hepatic veins. That's why it's important to get your nice branches. Try and visualize as much of the hepatic veins, your right, middle, and left, flowing through the liver. This thrombus could potentially be developing, in the liver itself and then extending into the IVC. So we're going to image the IVC, the portal vein, and any collaterals. With ultrasound findings, we're going to look for hepatomegaly, heterogeneous architecture. So instead of a nice, smooth, homogeneous, the liver becomes more heterogeneous. That's a result of microthrombus developing within the liver. We're also going to assess, look for the presence of ascites, partial or incomplete inability to visualize the hepatic veins. We'll look for areas of stenosis or dilatation of veins, thickening of the venous walls. So remember, our hepatic veins are nice thin walled, whereas our portal veins have the thicker epigenic walls. So if we start seeing the portal veins developing thick walls, this could be development of thrombus along those walls. Again, looking for presence of echogenic intraluminal materials, so intraluminal echoes within those hepatic veins, documenting the absence of flow, stenotic flow patterns. Because remember, with our hepatic veins, we have a nice, that W, so triphasic flow. So when we start seeing changes in what our normal hepatic vein flow pattern is, we just start raising signs, red flags that this potentially could be a issue with Budd-Chiari or thrombosis of these vessels. So if we wind up with more monophasic flow and that less respiratory variation, could be, start raising red flags for you, as well as visualization of intrahepatic collaterals, so collateral vessels within the liver that are developed to get around those areas of thrombosis, as well as possible portal flow abnormalities. So if things are now, backed up through the liver and are affecting the portal vein, we could potentially see changes in our normal portal vein flow as well. So Budd-Chiari syndrome, we have some morphological changes and extrahepatic manifestations. So in the acute stage, when it's first occurring, we develop hepatomegaly, again, because now the liver is not draining properly. So things are backing up to the liver. Liver becomes engorged with blood. Liver may appear hypoechoic at this point. Outside of the liver, we start developing ascites, pleural effusion, could potentially have gallbladder edema, so thickening of that gallbladder wall. So this is the body's attempt to try and, take some of that stress off, remove blood flow, blood volume, so it removes water out of the blood. That's what creates the ascites and the pleural effusion. As it progresses in the more chronic stages, the affected areas become fibrosed. They start to shrink in size. So when they become fibrosed, the tissue becomes more echogenic, more heterogeneous. We'll wind up with caudate lobe and left lobe enlargement. Remember that the caudate lobe has its own blood supply, so it's typically not affected, so it's going to appear much larger in comparison, to the right lobe. Extrahepatic signs, again, we now can potentially wind up with splenomegaly and portosystemic collaterals. So this is Budd-Chiari syndrome, and so this would be a primary example of primary Budd-Chiari syndrome, because this patient has a membrane obstruction of the IVC. Down here, pointing to this little echogenic flap that's blocking the IVC. This would be a congenital defect. So we have dilated main hepatic, middle hepatic vein, reveals numerous echogenic intraluminar linear structures consistent with webs. So two most common findings on grayscale are overall hepatomegaly and selective hypertrophy of the hepatic lobe, caudate lobe, sorry. In acute cases, extensive hepatic vein thrombosis can manifest as hepatic failure, liver enlargement, and massive ascites. Visualization of hepatic veins may be difficult in chronic cases, which is true. When the liver becomes very cirrhotic, the penetration of our ultrasound beam to the liver starts becoming limited, and we lose a lot of visualization of our vasculature details. So anyone who's scanned, a nice cirrhotic liver, being able to visualize these intrahepatic vessels becomes quite difficult. In chronic cases, hepatic veins may also be difficult to see due to fibrosis and decrease in size. Enlarged caudate veins are present in approximately 50% of cases. And in the absence of heart failure are a specific sign of Budd-Chiari. So this is a picture over here with our left lobe of the liver showing a very enlarged caudate lobe. So here we have a couple of pictures showing our hepatic vein flow. So this is showing the middle hepatic vein coming into our IVC. Most obvious Doppler finding is lack of hepatic vein flow, despite visualization of the vein on grayscale imaging. Here on this side, we could see echogenic thrombus within the IVC. We have our IVC coursing underneath the liver, got a couple areas of thrombus developing. So again, we're going to also detect changes or abnormal flow patterns within the hepatic veins. This, again, it's going to raise red flags for you that there could be potential issues for hepatic vein thrombosis. The color view connecting hepatic veins shows one vessel is antegrade while the other is flowing towards the liver. So the branch with reverse flow is supplying a collateral. And we have a loss of normal hepatic vein pulsatility. So you can see this is very monophasic forward flow, whereas our normal hepatic vein flow, we have that triphasic waveform below the baseline that has the respiratory variation and pulsatility. So when collaterals develop, the hepatic vein supplies the collaterals will have reverse flow. This produces the typical appearance where one hepatic vein branch is flowing hepatofugal in the hepatofugal direction towards the IVC, and a communicating vein is flowing away from the IVC in the hepatopedal direction. Because hepatic vein thrombosis isolates the hepatic vein from the right atrium, the pressure fluctuations of the right atrium do not get transferred to the patient portions of the hepatic veins. So therefore, hepatic vein loses its pulsatility and becomes monophasic. So this is an oblique view of our right liver showing the middle hepatic vein communicating with collaterals. Color flow shows antegrade flow in the middle hepatic vein and reverse flow in the collateral. And the collateral vein communicating with veins in the caudate lobe that drain into the IVC. So C is just showing caudate lobe. So this is a collateral vessel coming down your main middle hepatic vein, normal flow direction. So if this was a collateral connecting to that, it should be flowing hepatofugal, but in this case, We have reversal of flow. So because hepatic vein cannot flow into IVC in a normal way, collateral pathways develop. Collaterals are most frequently seen draining to non-obstructed hepatic veins, such as an accessory hepatic vein or the caudate lobe veins. Again, so if this is a chronic Budd-Chiari syndrome, patients will also develop splenomegaly. So just to kind of recap, a normal spleen size should be less than 13 centimeters long, less than 6 centimeters thick. Normal spleen should have a nice homogeneous, even extrotexture. It should be crescent in shape. Sagittal view. Measurements, kind of measuring tip to tip to the diaphragm. And then a transverse view, where we get our thickness. Measure the thickness at the hilum. So we also have to think of the organ as being able to infarct, meaning not getting adequate blood supply where the tissue undergoes necrosis and death. So the liver can exhibit areas of infarct. So ultrasound showing a hypoechoic area of infarct within the right lobe. And then a CT image showing low attenuation of that same area in the right lobe. See this large area, the right lobe of the liver. So it's very hypoechoic. You can also have development of hepatic calcifications. These are calcified granulomas. So again, anything that's calcified, or not anything, but like when something becomes again highly calcified, we will have our posterior shadowing. So similar to gallbladder calculi, these are going to shadow as well. When we put our color on, we should also be able to demonstrate twinkle artifact in these structures. It's always good to image in multiple planes. So this is actually a picture now of a gunshot shotgun pellet within the liver. We have these comic tail reverberation artifacts coming down. So in instances where we have hepatic trauma, we can develop hematomas. So hematomas are going to appear very heterogeneous. They'll have mixed ecotexture, so you have areas that appear more cystic, areas that appear more echogenic or hyperechoic. A lot of times with hematomas, you'll have a dependent portion that appears more cystic. So if they're blind, the part of the blood that's part of the hematoma that's still liquid will be more dependent, and more, superior portion will appear more echogenic, whereas the fibrin strands start clotting together. So this over here is actually a subcapsular hematoma. You can see it's very echogenic. Very complex areas of cystic and echogenic and hyperechoic areas. So with these cases, you also want to put color on to make sure that there's no active bleed going on within these hematomas. They could potentially be expanding and still bleeding. So another thing that we can potentially encounter is hepatic veno-occlusive disease. So this is most common in patients following hematopoietic stem cell transplantation. Risk factors include bone or blood marrow transplantation, patients with pre-existing liver disease. It's more common in women. Potentially be a result of mismatched donor bone marrow. Also seen in potentially prior radiation therapy, patients who've had prior radiation therapy, or patients with liver transplantation. Signs and symptoms include hepatomegaly, tenderness of the liver, right upper quadrant pain, swelling, weight gain, ascites, jaundice, as well as abnormal liver function tests. So in this case, when we're Doppling the hepatic veins, we see narrowing and aliasing in the right and middle hepatic veins with increased velocities. So symptoms most often begin 3 to 6 days following transplantation. Patients with severe disease may develop renal or cardiopulmonary failure and mental status change. Tympanic venous flow obstruction and veno-occlusive disease occurs secondary to non-thrombus fibrous occlusion in the terminal hepatic venules and the hepatic sinusoids, which is thought to be precipitated by injury to venous endothelial tissue. Most patients are diagnosed clinically by elevation of the total bilirubin, right upper quadrant pain, and or an increase in body weight. Clinical signs and symptoms are non-specific. So differential diagnosis includes graft versus host disease, sepsis, cardiac failure, or persistent tumor. Doppler findings include elevated hepatic resistant indices greater than 0.75 and reversal of flow in the portal vein. So basically think of this as like a liver that has trauma, where you're starting to develop fibrosis that causes narrowing and stenosis of your intrahepatic vessels. And when you have that narrowing and stenosis, you're going to wind up with elevated velocities, increased resistive indices within these vessels. So it's kind of like a stenosis or occlusive disease that's caused by some of these factors, like primarily patients who had liver transplant or some sort of bone marrow transplant or pre-existing liver disease. Questions about any of this occlusive diseases? So the main thing by Chiari is hepatic veins and IVC, portal hypertension, portal vein thrombosis, blood flow entering the liver, Chiari syndrome is blood flow exiting the liver. Our tip shunt, most common location for the tip shunt is connecting the right portal vein to the right hepatic veins. We look for high velocities within our tip shunts, or maintained high velocities. When we start seeing decreases in the velocities within those tip shunts, that can be a sign of failure. We also are looking for signs of stenotic lesions within our tip shunts. So if you have any areas of focal increases, that could be an indication too of tip shunt failure. So we should have nice uniform velocities through our tip shunt from beginning to end. Tip shunts, we use that to take pressure off the portal vein in cases of portal hypertension to try and prevent the development of portal vein thrombosis. The main causes of portal hypertension, cirrhosis. That's going to be the number one cause, hands down. You guys go with like your liver segments and vessels. Why aren't you responding? It's okay. It caused a serious error. Do you still want to open it? Yeah, sure. What? Doesn't like me. What was that? We'll just do it from here. There we go. All right. So test validation and statistics. So start off to find some statistic terms, statistical correlations, and methods of calculations, and then we'll do a couple of examples and practice questions. So definitions of terms. We have test criteria. So these are results that classifies the test as a positive or negative. We have the gold standard. So this is a reference test that is assumed to be the truth. So in medicine, we usually have one particular test or exam that we like to consider as the gold standard, and then we compare other different types of exams or tests to that gold standard. So we have also another definition, which is true negative. So this is when the gold standard is negative, or whatever test is says it's negative, and our test is negative as well. We have a true positive. So the gold standard is positive or abnormal, and our test is positive. false negative. So that's when we have our gold standard says that the test should be positive but we're getting a negative. And then a false positive is when the gold standard says this person should not have disease or should be normal, and our test is saying it's positive. When we start actually showing examples, like these terms will make a little more sense of false positive, true negative, false negative. So a couple other definitions. We have sensitivity and specificity. So sensitivity is the ability of the test to detect disease. It's the percentage of abnormal gold standard results. Specificity is the ability of the test to identify normality. This is representative as the percentage of normal gold standard results. We also have positive predictive values and negative predictive values. So these are the percentage of test results that actually predict an abnormality or disease. And then negative predictive value is a percentage of test results that actually predict the absence of disease or normality. And we're also able to calculate overall accuracy of our test. This is the percentage of correct test results. Prevalence is the percentage of the entire group to have a disease. So how prevalent is that disease? We're able to calculate the percentage of the entire group that actually has a particular disease. A high false negative rate leads to a low specificity, and a high false positive rate leads to low sensitivity. And another thing, this is important too when you're looking at your multiple choice questions when you get to your registry. Your percentage of your accuracy or your accuracy value is going to fall in between your sensitivity and specificity percentages, as well as in between your positive and negative predictive values. So when we set up our chart, we're going to be able to calculate what the sensitivity is, what the specificity is. We're going to be able to calculate what our positive predictive value is and our negative predictive value. And when they ask you an accuracy question, that number is going to fall in between all those values. So it's going to kind of lie in the middle of your sensitivity, specificity, positive predictive, and negative predictive values. So on your test, you'll be able to do, process of elimination with your multiple choice and be like, all right, that one's in the middle. I'm actually going to
before you make this statement, on testing, you're going to get a little whiteboard type thing.
So I found this guy on the internet. He does a pretty good job like
You'll have
breaking it down.
That period of time where you can either read the instructions about how to take the exam, which I don't recommend that you do. It's very self-explanatory. And instead, use that time on your whiteboard to draw in the 4x4 table with the values and the formulas so that everything is sitting there for when you encounter a biostats question. So let's get started with how you actually fill out this 4x4 table. So the first thing that you do in the 4x4 table is you have to know where the positives and negatives go. So this is where they belong. The positives are up at the top left corner, and the negatives are the boxes that go to the right and down more. So this is how you have to fill this out. And this is important because you have to know what these axes represent. So Across the top, you should write reality, and across on the left side, going from top to bottom, you should write the word test. So what this means is that
So let's say you have to read an incredibly long email from your boss that you have to finish before the big meeting starts.
on the left side, that's
So he wrote reality. I usually write like disease. Put or and then on this side we're gonna write a test. So what this means is positive and negative. So we're gonna test the patient for a particular disease, like whatever test we're doing. We'll use COVID for example. So a nasal swab test. So our test can either come back positive or negative. So the patient can either positive for COVID or negative for COVID. And then this is across the top, I'll put has disease. So they either have the disease for real or they don't have the disease. So patients are gonna fall into one of these boxes. So so this first box is gonna be, they tested positive for the disease and they actually have the disease, so has the disease. So that's gonna be considered our true positive. True positives. So the test showed that it's positive and they actually have the disease, has the disease. So if they test comes back negative and they actually have the disease, that would be a false negative. So if they test came back positive and they don't have the disease, exactly, false positive. And if the test came back negative and they don't have the disease, that would be true negative. Okay. That's the first step of kind of filling out your chart. So across the top, does the patient have the disease, has the disease? And then what the test results. These are your test results.
shows. So the test was positive, but the test for the disease was negative. And on top, it's the reality. In reality, if it's positive, you actually have the disease, or in reality, if it's negative, you actually don't have the disease. So that is how you sort of move through. Now let's start filling in these tables, specifically in these boxes. So let's look at the top left box. If in reality, it's positive, meaning you actually have a disease, and the test says that it's positive as well, that is a true positive. Because think about it. If you actually have cancer and a test to test for lung cancer comes back and says, yes, you're positive for cancer, then that's a true positive because you do actually have cancer. Now let's look at the box just below that. So if in reality you have cancer, using our example that we just talked about, but the test comes back negative and says, no, you don't have cancer. But again, in reality, you do, that would be a false negative. Just think about it. You have it in real life, but the test is telling you that you don't. So therefore, that's a false negative. Now let's focus on these other boxes. We're going to start at the top there. If in reality, you don't have cancer, but you get a test that says you do have cancer, that is an example of a false positive. And now going down to the last box remaining in our 4x4 table, if in reality you do not have cancer and you get a test that says, no, you're negative, you do not have cancer, that's an example of a true negative. So this is how you fill out the 4x4 table. And this is where you have to start, regardless of which formula you're being asked for on your exam. You have to know where all these values lie, and you have to know plus and minuses for reality and test. So now I'm going to replace all of these with abbreviations just to make this lecture a little bit easier. So that's true positive, false negative, and true negative. I just changed the words to abbreviations, and I'm going to pop this in the bottom corner of our video so that you can refer to it as we move throughout the slides. Next thing that we need to go over is that when we're doing these equations for sensitivity, specificity, positive predicted value, and negative predicted value, all of the equations are going to be equal to something over something plus something. And I'll explain all of this. Don't worry if that's vague and confusing. But I really want to show you that all of these equations are equal to x over x plus y. And we're going to be drawing in arrows today. So if I draw in an arrow like this, the equation will be x over x plus y. And what the x and the x plus y represent is that the numerator is the back part of the arrow, so where the arrow starts. So in this example, you see a down arrow going from the true positive down into the false negative. So if we were to make an equation for that arrow, it would be equal to where the numerator would be where that arrow starts. The numerator would be 1, and the denominator would be where the arrow starts plus where the arrow ends. So the denominator would be 1 plus 2. So this is what I'm referring to here. In this example, you see the downward arrow going from true positive to false negative. So if I were to create an equation for that arrow using our 4x4 table, the dirty USMLE method, the equation would be equal to 1, because the numerator is where the arrow starts, over 1 plus 2. And again, the denominator is where the arrow starts plus where the arrow ends. So that's how all of these equations are going to work. If you are understanding everything to this point in the video, the rest is going to be a piece of cake. You're going to know all these equations really, really easily. So let's start using real examples instead of all these vague equations. So
you set up your table initially. There's a couple more things that we can add onto this initial table. So we can also add sensitivity. This first column, and then specificity. The second, second row. So first row is sensitivity. Second row is specificity. And then going across in our horizontal rows, we can have a positive predictive value and a negative predictive value. When we start drawing these arrows, when you start doing your equations, you'll be able to, you're basically just calculating either down a column or across a row to get your values. So when you get to your vascular registry, if you can draw this out with sensitivity, specificity, positive predictive, negative predictive value, fill in your true positive, false positives, they're going to give you all the numbers to plug into this chart, and you'll be able to calculate all your percentages.
talk about sensitivity. So how do we remember which direction to draw the arrow for the dirty USMLE method of learning the 4x4 table? So if you're overly sensitive in life, if you have too much sensitivity, you're just going to be constantly brought down because you're overly sensitive. Everything's going to get you upset. So if you're overly sensitive, you're going to be brought down in life. So we're going to use that to remember that sensitivity is the down arrow. We put our down arrow right there in our 4x4 table, going from true positive down into false negative. So don't be overly sensitive because you'll be brought down in life. Drop that down arrow right in the beginning of the table.
Friends would walk up to me and just tell her it's mud.
I love commercials.
Now, using the equation method that I
Keep it
described
PG in this
previously,
class.
let's go through how we write out the equation for sensitivity. So if we know that sensitivity is equal to x over x plus y, the numerator has to be where the arrow begins. So sensitivity is equal to the numerator being a true positive. Now we need to get the denominator. Recall that I said that the denominator is equal to where the arrow begins plus where the arrow ends. So sensitivity is equal to true positive over true positive plus false negative. Okay, makes sense, guys? Numerator is where the arrow starts, denominator is where the arrow ends. How do you know where to put the arrow for sensitivity? Because if you're too sensitive in life, it'll be brought down. So we have a downward arrow at the first eligible
So your
location.
numerator is always going to be the value
That's
that's in
sensitive,
where the tail
right
of the
there,
arrow
true
is.
positive over true
And then you
positive
just
plus false negative.
add both those values
Let's
and
move on
divide.
to specificity. So how do we know which direction to draw our arrow in the USMLE 4x4 method? Well, if you're really, really specific in life, then being specific is a good thing. You're going to move up the chain or up the ladder in the workforce, right? You're really, really specific. You get all your tasks done because of how specific and accurate you are. So being really specific moves you up in life. So specific going up. Now we're going to draw that into our 4x4 table in the next eligible spot. So specific is going up from true negative to false positive. Now let's work through our equation for specificity. So specificity is equal to x over x plus y. And again, the numerator is equal to where the arrow starts. So because the arrow is going up and it starts with the true negative, our numerator in the specificity equation is true negative. Now remember, the denominator is equal to where the arrow starts plus where the arrow ends. And therefore it's going to be is equal to, for denominator of specificity, it's true negative plus false positive. So that is specificity. So again, how did you know which direction to draw your arrow? Well, if you're really, really specific in life, you're going to move up the ladder in the workforce, and therefore we put that arrow going up, and that is specificity. So just to recap so far, here's what we have. If you're overly sensitive in life, you're going to be brought down by everything. If you're overly specific in life, you're going to move up the ladder in life. Those are your arrows. And remember, all of your equations are equal to where the arrow starts divided by where the arrow starts plus where the arrow ends. So this is where we are so far. Now,
Is everyone pretty good with that? Okay, not too bad. I like his little method of where the arrow starts and ends. I mean, that's a good method too. I just learned that I always took the true positive and the true negative. Like that was always my numerator, the true one. And then I just added the two and that became my denominator. But just, again, just being able to fill out your chart, sensitivity, specificity, and then he's going to get into positive and negative predictive value on the other side for our rows. And it's just, it follows the same method. We'll see in a moment.
not too bad. You already know sensitivity, you already know specificity, you already know how to draw the 4x4 tables. You guys are doing great. Bear with me. Now we're going to talk about positive predictive value. So positive predictive value, to figure out which way the arrow is going to go, we're going to use a numeric grid or a graph grid. Now, if you're really, really positive, you just move in the positive direction. Pretty easy for anyone who took 9th grade math. So I hope that you guys are with me. I hope you passed 9th grade algebra. Here we go. Positive, you're going to move to the positive side on the graph. Therefore, we're going to stick our arrow in our 4x4 table for positive predictive value. So positive predictive value is equal to the numerator over the denominator. What's our numerator, guys? That's right. It's where the arrow begins. So it's equal to a true positive. What's our denominator? It's equal to where the arrow begins plus where the arrow ends. So therefore, it's over true positive plus false positive. You guys are murdering this. You're killing it. Excellent job. That's positive predictive value. So again, how did you know where to draw your arrow? Well, it's positive predictive. So positive, moving in the positive direction of a graph. You draw it from left to right in the first eligible spot of our 4x4 table. So here's a recap of where we are so far. We already talked about sensitivity and specificity. Now I'm just going to throw in positive predictive value, and you should be able to derive all the equations from knowing these arrow directions. So obviously we're going to wrap up with negative predictive value. Again, we're coming back to that graph that you should be familiar with if you made it through high school. So negative predictive value, it's probably no surprise, guys and gals, our negative predictive value arrow will move in the negative direction. So if we throw that into our 4x4 table in the only spot left that you could possibly put an arrow, negative predictive value is going to be equal to x over x plus y. What's the numerator? It's where the arrow begins. So it's a true negative. What's the denominator? It's where the arrow begins plus where the arrow ends. That's true negative plus false negative. So negative predictive value is going to be equal to true negative divided by true negative plus false negative.
So if you ever forget arrow directions and all that, your numerator is always going to be one of these two. It's either going to be your true positive or your true negative as your numerator. And then you just, depending on whether you're doing negative or positive predictive value or specificity versus sensitivity, determines, which two values you're adding. So which direction you're going across your chart. So if you could draw this and just know, sensitivity is for your columns and the negative and positive predictive value for your rows. These two are always going to be your numerators. So if you're doing positive predictive values, that's going to be your numerator, and then you just add the two of them for your denominator. Same thing, your numerator, and then just add the two of those for your denominator. And then if you're going the other way, numerator, add those two for your denominator. Really, it's not bad at all. Just registry day, first thing you do when you walk into that test center, just draw that. And you got, probably 10 questions done.
So in review, here's where we are. We have you're overly sensitive in life, you're going to be brought down, so the red arrow goes down. If you're overly specific in life, you're going to shoot up the ladder in the workforce and you're going to go up.
Anything else?
Please mark because there are 3 points on your testing. Please understand this, please know it well. And here is the summary. If anybody needs the mnemonics for how you got here, here's where we are. Positive predicted value moving.
So the last thing that you can add on is accuracy. So accuracy, this one goes at a diagonal now. So if you wanted to put accuracy onto your chart in that bottom corner, your values you calculate at a diagonal. So accuracy again. Yep. So numerators, like I said, your numerators are always going to be these true ones. So with accuracy, you have 2 true ones. So those both become your numerators. So you add those 2 together. So that's still, these values are still going to be your numerators. So as accuracy goes at an angle, you have 2 numerators. So you add those together, that becomes your numerator. And then your denominator is everything. So here you go. So here's your formula for accuracy. True positive plus true negative divided by everything times your 100. And just remember, accuracy is going to fall somewhere in the middle of all these values. So you'll have it, they'll give you, you'll have all these values on your test potentially, they'll have, 87% this, 70% that, 60%, 50%, whatever. And then what is the accuracy for this test? So without even having to do calculations, you could look at all of the values that you got, and your multiple choice questions, one of them is going to lie outside of that range, of the range of these. So you're going to pick that one value that lies in the middle of the range of all of those. And then prevalence. So prevalence is a detection of how much disease there actually is, or how prevalent this disease actually is. And that is adding the true positives plus the false negatives and dividing by everything. Prevalence is just going to be this first column, adding the true positives and false negatives. So it's basically how many people actually have the disease. So if you go back to your has disease, this is a measure of how many people actually have the disease. So the people in this row, this column that actually have the disease over all the people within your study. So over everyone, that's your prevalence. How many people actually have the disease, or how common is the disease, or prevalence of the disease. So basically everyone, who actually has the disease compared to everyone within your study. This is an example of how these questions are going to look. You can draw out your table and you kind of read through the questions. So you have 140 patients had non-invasive and invasive venous studies. 68 of the studies indicated acute DVT, while 54 showed no evidence of disease. In 12 of the studies, the non-invasive studies were negative, but the venogram was positive. And 6 of the studies, the non-invasive studies were positive, but the venogram was negative. So in this case, the venogram is going to be your gold standard. And then the non-invasive studies can be your ultrasound exam. So the non-invasive studies were positive, but the venogram was negative. Calculate the sensitivity, specificity, positive predictive value, negative predictive value, and accuracy. All right, so negative venogram. So in 12 studies, we can do the non-invasive studies were negative, but the venogram was positive. So that would be our test is negative, but they actually had the disease that was positive. So we could put 12 into our false negative. So 68 of the studies indicated acute disease. And 6 of the studies, the non-invasive studies were positive, but the venograph was negative. So that would be a false positive. So this is 6. 68 of the studies indicated acute disease. Positive. And then 54 true negative. So then once you have all your numbers in, you can then start calculating your values. Over calculators. Oh, we do have calculators on our phones. Sensitivity, that's 68. 78. Specificity, we got 4. Predict the value. 74. Predict the values. We got 4. On the registry, they're going to give you nice even numbers. So the math is very simple. God bless Lily giving us hard calculations here. She's probably doing them in her head like. Okay, where's my calculator? There we go.
Ninety-one percent.
91. And so then, yeah, so 85, 90, 82. You guys all get these? Yeah. Then you can see that your accuracy is going to lie within the middle between those values. So it's going to lie in between your specificity and sensitivity. So 87 is in between those two. It's going to lie in between your positive and negative predictive values. So on basically any registry request, when they do the accuracy, like you don't technically, if you ever forget, like, oh my God, what's the accuracy one? You can kind of look at all your choices and know it's going to lie in between these two. It's going to lie in between these two. So you pick your answer that lies in between both of those. Yeah. Goodness. This one looks interesting. Toe amputation site. The table above shows data used to correlate ankle pressure measurements with healing in patients whose toes have been amputated. The gold standard is the healing of the amputation site. For the purpose of this study, a positive ankle pressure was greater than 60. Calculate sensitivity and specificity. Positive crash. So our test results, so positive would be something greater than 60. Oh, okay. These eyes got to be
Yeah,
I'm looking at this, I'm like, this doesn't make any sense.
yeah, and 27 is her
All right, so not healed is 15.
and 5.
Yeah. So
True positive is 3.
3, yeah.
Negative positive is true negative is 15. False positive is 5. It's false positive.
Oh, sorry.
I don't know.
No,
But
you're right.
it's
No,
still-
you're right.
I'm not.
Yeah, this is
This
really-
is really
Yeah.
confusing. She has it like, if you look at the next slide, she has like the answers to it.
Yeah, it's
Opposite.
false negative. It's 5. Yeah, that's because it's not head. Yeah.
That's a hard one. I don't
Yeah.
like that one. I was like, oh, this looks interesting. Yeah, this is better. 400 patients underwent invasive venous testing with subsequent venography. Comparing results, it was found that 300 patients whose venogram was normal. 15 had shown abnormalities on non-invasive tests. 300 patients who 300 patients whose venogram was normal. We had 300 patients were a true negative.
Was normal.
Yeah.
True positive. Okay.
So 100 patients whose venograms were abnormal.
Normal.
90 had shown abnormalities.
True positive.
So wouldn't 15 be the false negative, right?
Yeah.
Am I reading that right?
True.
Wait, no, 15 showed abnormalities. So that,
True negative.
no, yeah, that's a false negative. So 300 patients had
Normal.
their venogram was normal.
Yeah, like looking at the next slide here, just thinking to myself.
15 had shown abnormalities.
Abnormal. So it's true negative.
She has it under false positive. So this is where I'm getting confused, because now I'm just confused. So the venogram is the gold standard in this case, right?
Yeah, so
Okay.
400, we have 400 total. 300 patients had the venogram and they were normal.
I think we should write this out,
So that'd be-
like on the board, like write this out somehow or something. Like,
So if venogram showed us 300 patients are normal. So that one is true positive. No, it's true negative.
true negative.
Yes, true negative. Sorry, yeah, true negative.
15 had shown abnormalities.
True positive. Yeah. 15 is true positive.
Oh, she subtracts. You know what it is? So 300 showed that it was normal and 15 actually, of those 315, so it's really 285. So 300 patients had a normal venogram. Of those 315 actually had an abnormality, so that was a false negative. So 15 would be a false negative. And then the ones that were true negatives were 285. So of
Okay.
that 300,
Yeah.
285 were true negatives.
Okay, I just understand that's 50 from
15 is
10.
false positive.
False positive. 15 false positive because they are they have abnormal results.
That are still normal, but should have normal.
False positive. Yes.
Yeah,
false
false
positive.
positive.
So they actually
50.
they're false
Oh,
positive.
100 patients from venogram.
God, I'm confusing myself.
Yeah.
So of the 100 patients whose venograms were abnormal, 90 shown abnormal.
True positive. Yeah, true positive 100. Yeah, that's true positive.
90 whoever true positive, they should have true positive. Abnormal, so,
Oh my god.
Yep.
Only positive is normal.
and then out of the rest of them would be 10
Yeah.
at the bottom. False negative.
Yeah.
They're abnormal.
Two different groups, 3 for 15 were
Abnormal. So until the rest. True negative. What's that?
Sample from data. So this is more,
Complicated.
no, this is like more, not more complicated. This is like more like what's on the registry. So 200 carotid arteries in 100 patients had digital subtraction angiogram. Positive exam was registered if the patient had a 50% stenosis. A negative exam was reported if the patient had less than 50% stenosis. So 120 had a positive angiogram. So our ultrasound exam indicated 105 had a positive scan. So that would be a true positive. 105. So then patients who had the test result positive but had a false positive, you just subtract the 105 from 120. So I'm just looking at the test results. So we had 100 people for our test. 120 tested positive for that test. 105 with ultrasound were true positives, found to be true positives. And the other 15 were false positive. So 80 patients total had a negative angiogram, so our test was negative. Oh, okay, I'm sorry. Doing this backwards. Ultrasound exam was negative in 95 scans. 80 had a negative angiogram. Have enough.
False negative.
So angiogram is in the test, ultrasound is the test.
Oh, where did this aid?
Five. Yeah, well, false positive. Negative 15.
Yeah, but I don't know. Yes, she's correct. Look, for 105, they got like ultrasound, and the other one they got angiogram. That's the difference. So we have to make like comparison between 120 and 80 now. Yeah, because look, 120 had a positive angiogram, and the other 105 ultrasound exam. So that's the difference. And we have 80 had a negative angiogram.
Statistics, I know.
Literally. This is also a great start. I'm so excited for boards. So.
Go statistics.
Can we just look at what she said and maybe we can try to understand it?
Yeah.
Because I think just staring at these numbers, we're not understanding her logic. Okay.
One possibility.
Positive.
So then
She added.
No, go ahead. Okay, so there's 120 positive angiograms.
Angiogram.
So that means in the total, like positive of ultrasound and angio, there has to be 120.
Exactly.
So angio and the whole positive down column, there has to equal 120.
Okay.
But 105 were positive in the ultrasound. So that
Yeah,
means
trust
on
me.
the ultrasound side, it has to be 105 of the 120, which is why the 105 is there.
Yeah.
So then that means the rest, since there's 120, that means out of all of those 120, there was only 15 negative.
50, yeah.
But that false negative. So then there was 80 total negative angiograms, like all around, and the ultrasound exam was negative in 95 of the scans. So that's why there's 80 total angiograms that are negative, so
I don't
true
understand why she
negatives.
has false
She put
positives here.
angiogram in the top and
Why is she have false
ultrasound.
positive here?
Yeah.
Are we doing this wrong?
No, that's wrong.
Yeah. No, I mean, that's,
She has it right on the section, that's.
Yeah, she wrote angiogram and the ultrasound, they're different. Like,
yeah.
You see what I'm saying?
it was
So like,
standards.
so it's saying like out of all the negative, there needs to be 80 negative angiograms total, which is why that 80 is in the negative angiogram side.
Yeah.
And the ultrasound was negative in 95 of the scans, which is why that is, it has to be a total 5 of 95 scans. Does that make sense?
I agree.
And there was only, and there was only 200 total patients. So if you have 105, 15, and 80, that's already 200, which is why the zero's up there, because you don't have any more patients.
Mhm.
So like the total is 200 carotid of them. Does that make sense? And you have 100 people getting an angiogram.
Like, we have here like two gold
It
standards,
makes sense in my head,
angiogram
it
and
makes sense, I just don't
ultrasound.
know that.
But she still has
I get it. in my head.
Why did she do that?
What?
It's a false positive on the bottom. Like, how can I ignore it? How am I supposed to ignore that?
You are back.
Like. I think we need more examples and better ones,
Yeah.
easier ones. Smart ones she gave us.
Yeah, this here is false negative. Like that should be false negative.
Yeah, first-
False negative. False
Yeah, it
negative.
might just be.
Okay, so
I think she might have just made like
False
a
negative.
error, like a typing error. I think she probably has.
So
some
do we
error.
still think 15 is on the bottom?
Yes,
Okay.
I do. I think that makes sense, because you have to have a total of 100 positive angiogram cases, so that would make it 100 total positive angiograms.
Okay.
Because 105 plus 15 is 120.
Hold on, let me, while you're explaining this, let me look at what it says. Okay. All right, go again.
Vascular. We'll take right from the vascular.
I already passed my math class to get into this program.
Yeah, what?
The hell is this shit?
I don't even like schools. So 15 would be.
Needless to say, none of us will ever be in research for vascular.
Okay, will you come here? So 15 would be false positive, because on the angiogram, it was actually negative, but the ultrasound is negative, is positive. So that's a false positive, right? The
Are you even
15,
on the right one?
I think so, right? Are you sure?
Because I was like, wrong that one.
Okay, all right, so.
Try again. So you get what I'm saying?
Abnormal.
So like out of your pod, this is the angiogram side right here. And
Yeah.
this whole thing means there's a positive angiogram.
Okay,
Does that make sense? It's why
Yeah.
this ultrasound shows a false negative.
okay.
Because it's not negative, it's actually positive because the full
The
standard said it was
angiogram
positive.
said it's positive.
So there has to be 120 people in this column.
Okay.
So if you have 105 on the ultrascan that were positive,
Mhm.
and the angiogram that were positive, does that make sense? That's why you put the 105 there, but you have to have
Yeah.
a total of 120, which is why
Okay.
15 goes down here.
Mhm.
Does that make sense?
Yeah.
Okay.
So then,
80 had a negative angiogram. So it was a
80.
true negative,
okay.
right?
80 would be down here.
Yeah. And there has to be a total ultrasound exam was negative of 95, which is like 15
So
plus
then-
80 equals 95, and the ultrasound exam for a total of 95 negative. That makes sense.
Yes.
So
Okay,
then
so then
9,
that
so
would
then
be
85 plus 15 is 100, or I'm sorry, 95. So it's what, 80 plus 15 is 85. Plus the 105 is a total of 200, right? There's only 200 carotid arteries,
Yeah,
which is why that's 0.
okay,
Does that make sense?
maybe.
No.
Yeah.
Can somebody explain this?
Don't know how to, like.
No, you're fine. It's just like.
Come down faster.
My dad would be so happy right now.
He's doing a different one.
No, I know, but 120 patients have to test 132 of the non-invasive. Sorry, I just was starting to do it, and then I was like,
Yeah.
hold on a second.
I'm gonna write it out and we'll see if we can break it down. Very mild. thought to have significant. Angio. Three. Were thought to have be within normal limits by duplex, height significant disease by angio. 3. Duplex. Had significant disease on angio. I think some of this might just be like extra information that kind of throw you off. Awesome. Let's see. However, there's disagreement between the invasive and non-invasive in 10 patients. So, let's see. 3 were thought to have significant disease by duplex, but showed mild disease by angio. So that would be a false positive. So 7 is going to be false positive. 7 were thought to have significant disease by duplex, but angio showed that they didn't have disease, it was mild disease.
Also not false negative. This ultrasound showed positive, but it was really negative by angio. So that'd be false negative.
They don't, so they don't actually have the disease, but our test showed positive.
Yeah, wouldn't that be false positive? So what Lily has on the chart, she doesn't has the disease on top, she has the gold standard test results.
Yeah,
So on
maybe
top,
angio would be on top.
yeah,
Or angio.
yeah. And duplex results would be on the left. Yeah, maybe. Yeah. So maybe that'll help us with these. Okay, so where were we? 7 were-
7 were thought to have significant disease by duplex.
So that would
It showed-
be,
True,
Three would be false positive.
yeah, so 3 would be false positive.
yeah, true. But ultrasound,
7 thought to have disease by duplex, so the test showed a positive result,
but in.
but the angio was negative.
But like would mild disease be negative or? That's where I think. Like is mild disease considered positive or
So-
negative? Like technically there is something there. I don't know, this is what my brain is. I hate it.
No,
Yeah,
I definitely,
With negative.
because like the other one says 3 all were normal by duplex, but okay, so the other one says mild.
So that 7 is false positive?
I really hate this.
Yeah, so 7 was false positive,
False
right?
positive.
Yes.
Okay,
So that would be 10 now, yeah.
and then 3 were saw normal by duplex, so that would be
Normal by
negative on the left, 3,
So
but then it's actually positive, so false negative would be 3, right? Okay, so 2 numbers are on there now.
That's what I got for three. That's
And-
what I was wrong. I said false negative was 3. I know.
Yeah, 100. So
I actually,
I just had that.
I was actually confused, I'm sorry.
for true negative, 100, please.
So
Yeah.
both
False.
the non-invasive and invasive studies documented
Citronic.
hemodynamic significant stenosis, so our duplex was positive and the angio was positive in 132, so both tests.
Yeah. True positive.
132.
The 98 would be
What's the
true
98,
negative, right?
True negative. By both.
Both
So
negative.
negative.
So they were both negative, right? So then
True.
98 would be true negative.
So I guess they're
By
saying like
both.
mild occlusive disease would be a non-hemodynamically significant disease. Maybe like, less than 50%.
Mhm.
Now we have time. That's very neat throwing this.
Yeah, that's confusing.
It's the numbers we have in the book. too. With your echo boards, they particularly like doing that, throwing a bit of information that has nothing to do with the question to kind of take you down a road. Oh. The value is 97. Accuracy 96%. So again, accuracy lies in between those two and a line between those two.
Yeah.
We'll practice more. I'll try and find one that's not crazy. Yeah, there'll be one.
Okay.
I'm gonna make one up.
Yeah, make one up.
Make one up that makes sense.
Okay.
Yeah, more. I put it in the box. All right, this is one. Right.
Save explanatory.
So that is it for today.
Mm.
Oh, yeah, I almost forgot.
What?
I was gonna pop out.
Oh,
So we updated the program manuals to change some of the language to include trajectories into it. So where is it like, it's like mentioned like paper documents, we like inserted like, you know, the words trajectories. They're highlighted into the program manual and available for you guys to review on D2L. And the other change was with the clinical competencies to reflect the new accreditation standards. So it's that new chart that shows like all the clinical competencies now. Changes. But Kathy wanted me to have you guys, you know, sign off that you know where to find the program manuals, like on D2L. They've been updated since we reviewed it like first semester. The document has been updated since I received my first year manual. This program runs. This part is- up here.
Did she give you those printouts? She'll give you all. And then the PowerPoint. Yeah. And it goes like literally by in order, the way they do it, so nice.
Yeah, one is
I brought
for
it in with me, I'll
the
just go through it while they go, it's so nice.
allied health, and then the other is for program specific.
She'll print them out for you too. She has an appendix one.
She gave this to me, it was already kind of like, that's how I do the drawing of it, and then this is photocopy.
Are they giving you a hard time to get into AI?
Good luck. Good luck getting in there today. You don't have access to it. Unless you follow an employee in.
Yeah, sometimes I have to just on Wednesday, somebody opens the
That's
door.
what that's literally what I had to do. I would just stand there until somebody would come by and I'd be like, sweet.
I'm just like, no, just stand there.
Like, who's this person just standing
I know, and then I feel awkward. I'm like, what if they're just like, what if